I know a few people are still connecting to audio, but welcome, good morning, glad that you're here. This is our 6th Behavioral Health Urgent Care Crisis Stabilization Workgroup meeting. Believe it or not, it's already November. I feel like 6 months ago we were saying, oh, we've got plenty of time. November is so far away, but here we are. So welcome. If you wouldn't mind, please, a couple of things just housekeeping wise. Please enter in your name, title, organization into the chat box by way of introduction. And also just a reminder, as I always remind everybody, we do record these meetings and we post the recordings as well as the agendas and meeting minutes to the Behavioral Health Plan website, which is planforchildren.org. That's where we store all the information for this work group and the other ones that have been meeting recently. And I think that covers it. So we're already recording. I'm going to pull up the agenda briefly and just run us through what we're going to talk about today. And then I will turn it over to Tim in just a moment. But today we are going to let's revisit these work group goals. We wanted to look at federal and state initiatives around this crisis care continuum, define core components of the crisis continuum in terms of services as well as needed infrastructure. We wanted to draw upon the literature and expertise in Connecticut for considering a couple of models of care, one a 23-hour urgent care model and one a 1 to 14-day crisis stabilization unit. And then finally, all of this rolls up to the Children's Behavioral Health Plan Advisory Board, as well as the State Department, 12 State Department commissioners. As I mentioned, we're up to our 6th meeting here, and we'll talk at the end about next steps and where we go from here. Hopefully you all received the outline of crisis stabilization model parameters, as well as a few questions, and we'll probably just verbally kind of go through a few questions and discussion. And by the end of the meeting, we want to save a good chunk of time to identify some next steps, and we'll wrap up on time at 11 o'clock. So with that, I will turn it over to my colleague, Tim Marshall.
So good morning, everybody. Thank you all again for joining us. It's great to continue to have such a strong and robust turnout for this. Originally, we thought that today would be our last meeting, and it may be. We'll make that final decision with you all at the end. We won't have a final document at the end of this for the crisis stabilization level of care, but we have a couple of all options for us to finish up the work. So we'll talk about that before the end of the meeting. So just wanted to make that comment. Number 2 is just a reminder, these 2 levels of care that we set out to put forth for Connecticut, recall that we have said all along that both of these in the form that we're putting forth as recommendations would be considered long-term implementation strategies. When you start talking about needing to develop an alternative level of care to the emerging department, that will require legislative action. And so there will be no short way to implement this model for the alternative to the emerging department. I also just want to remind folks that in Connecticut, in this work group, we did dub it behavioral health urgent care. But I do also want to remind people that the 23-hour alternative to emergency department is referred to with many different titles around the country. So I just wanted to say that out loud again. It's not automatically always referred to as behavioral health urgent care. I just wanted to remind people to that. And that is also true of the level of care we're going to be getting into more detail about today, and that is the 1 to 14-day crisis stabilization subacute level of care, which is just one step below inpatient. That too also has a number of different names across the country. And then finally, I would refer people back, and I know that it was a tremendous amount of information, and we did send out the entire packet early in this work group, but we also then sent some follow-up that had broken up the information. But if you spend a moment, if you have your spare time to do so, please refresh what the feds are suggesting states do as a best practice in the crisis continuum. These 2 levels of care are a part of that best practice. And the second part, another part of that best practice document really does suggest that the mobile crisis system in your state be kind of a hub and have the opportunity to direct admit and do direct assessments and direct placement and referral and connection to all the levels of care, including the crisis continuum. So just wanted to remind people of that. Next statement, just I want to be very clear and very careful. In general, this is a general statement. You know that if in fact you are thinking about providing services to DCF, you should be keeping your eye on procurements. So that's just a general statement, standalone, separate for all people always, people should always be having their eyes on that. And then lastly, the conversations that have been going on around the ARPA dollars and spending some of the ARPA money right now to get that out in procurements, that would mean that those would be shorter term implementation strategies. So again, I'm saying that out loud just to remind people that the priority is to make sure we get something out as quickly as possible. So it may be that we're not able to get a full implementation of these two levels of care quickly. That's again, just the bottom line on the way we have been talking about both of these two levels of care, that they're more of a long-term and not a short-term. So those are my reminders and just level setting us to this. And so today, our goal was to really spend the bulk of the time on crisis stabilization, really talk through how that should be working in Connecticut and how it would fit in the context of not only inpatient PRTF, crisis residential, for example, as other closely related bedded services, but also the emerging departments and whatever alternative to the emergency department or behavioral health urgent care, as we've been calling it. So those are, that's our goal for today. So thank you, Jeff, and I'll turn it back to you.
Okay. Let's address, because I know this question has come up a couple of times over the last couple of meetings. I'm looking at the chat box and seeing a question about respite care. So I'll start by trying to respond to that, but invite Tim and others to talk as well. I think this group was primarily charged with specifying the two levels of care that we saw on the agenda, the 23-hour urgent care, what we're calling urgent care for now, and then the longer term 1 to 14 day crisis stabilization. I think that respite is relevant to the extent that it would also be considered part of a continuum of crisis oriented services, even though I have to acknowledge that this group would not be able to boil the ocean and probably will not be able to extensively take on respite beyond just acknowledging that respite is part of that crisis continuum. And if it continues to be something that's of interest, I think we need to find avenues through the governance structures that we have in place for behavioral health to create a space to talk specifically about respite, because I just don't think that we're going to be able to get to it extensively in this group. So Sherry, I know that may not be the answer you want to hear, but I'm just trying to be realistic about what this group is charged with and has a capacity to take on. Okay. All right. Tim, anything to add to that?
No, the only part, again, I refer folks back to the crisis document that SAMHSA has put forth to states, and also a reminder, I know some of you do participate in the 988 coalition, but many of you do not. But the 988 preparation, all the state plans, within that context, the feds put forward model legislations for states to consider, particularly in the areas about how to fund your crisis continuum. One noticeable distinguishing factor about the crisis continuum is that although it's mentioned, crisis respite that is mentioned as part of the continuum, in their best practice model for what the potential taxes on telecom could pay for, I noticed that crisis respite was not included in that. So that if, number one, in that model legislations for states to consider, the feds put forward, states could choose and allow and created legislation to put a tax on our telephones in the same fashion that we are taxed to fund the 911 system. And then they went further and said, if your state chooses that route to fund your 988 system, you can also use those tax dollars to pay for these other levels of service. So if you develop an alternative to an emergency department, that source of revenue would qualify for that, for paying those. Crisis stabilization would qualify to be paid for. So those two pieces I noticed were mentioned as part of that federal legislation, but if I recall correctly, and again, I read this myself a number of weeks ago, so I'm going on memory here, but if I recall, I noticed that crisis respite was not among that which you could pay for using that tax. So I just say that out loud. We are monitoring the states across the country under the 988 work group, how many have passed legislation. There are a number of states that passed legislations. I don't believe that we have seen, I think there was one state that has already considered the telecom taxed, but we have not seen a number of states take that step. And in Connecticut, we have not heard a discussion about that. So it may be that Connecticut does not choose to go that way. And just remind people that it's not it's the executive branch and the legislative branch around how to fund the services that will come forth. So anything is, again, it's just a model legislation. So I see a comment from Carl. Yeah, that's well, I think the one thing we will say about the 988, what SAMHSA is stepping up to the plate with huge amounts of money to fund the infrastructure for the suicide hotlines, and those all being directed into the main system, the 988 system also. So there is a lot going on out there. So anyway, those are my comments around crisis respite.
Thanks, Tim. And Christine, thank you for linking to that SAMHSA best practices toolkit. I do think we were actually on the phone here right before we opened up and invited everybody into the room, saying that we had familiarized ourselves with those SAMHSA documents early on in the process. And now we feel, and probably would recommend to each of you as well, to go back to those documents and level set again around where the kinds of discussions that we've been having in this work group, and lining it up against some of those SAMHSA best practices, because it may be instructive for us to look at where we stand in relation to that again after a couple of months. Okay, so hopefully everybody can see that, but let's just kind of roll through a couple of things. We're going to, again, focusing on the last couple of months, we've been really on the urgent care or 23-hour model. Today, we're going to start to focus more in on the crisis stabilization unit model. And just a couple of slides just to get everybody on the same page around basic model considerations. But really the goal here is to just tee up enough information for you all to get going, as I know that you do, and start to inform us around the kinds of considerations we need to be looking at as a state as we think about crisis stabilization units as part of our continuum. So I think the first thing that we thought would be important would be to do some differentiation between crisis stabilization as we're currently conceiving it, or as SAMHSA has described it, from both the inpatient level of care as well as psychiatric residential treatment facilities. So CSU is intended to be a short-term, up to 14-day bedded unit that's community-based and unlocked. It's also, and Tim mentioned this earlier, this is true for behavioral health urgent care, and it's true for crisis stabilization. But when you look at, one of the difficulties of looking for literature for crisis stabilization is that you really can't look for that term to guide your search. You have to really look for model elements to guide your search, because they're referred to by so many different names. So you see things in the literature or in descriptions on state websites that refer to this level of care as subacute beds, or as crisis residential facilities, or short-term residential facilities. So that's a challenge for us, and means that you can get some good information from the literature if you have a broad enough search. But it also, I think, means that as a state and as a system, we can make some determinations about what we want this level of care to look like, irrespective of what we actually call it. Another point that we gathered from what our research up to this point, it's intended for youth who do not require an inpatient level of care. So that's sort of like the subacute element of it. And staffing would generally be less intensive certainly than the inpatient level of care, and often includes peer specialists. Again, remembering that most CSUs in operation out there are in community-based locations. And then the activities of the CSU look somewhat similar to the urgent care in a lot of ways, but over a more extended period of time. The focus is on supporting children and returning to the community, maintaining them in their home, school, and community, or quickly returning them there, and in a way where they're prepared with what they need to prevent future escalation or crisis, and then coordinating closely with the support system and with schools and other community supports that are in place. A few goals for crisis stabilization, and again, you're going to see some things that are very similar to urgent care. First of all, reducing utilization and reducing discharge delays from the general medical emergency department environment, as well as inpatient hospitalization. So frequently you see crisis stabilization used as a step down from inpatient care, and oftentimes also a step up from lower level crisis services. So just to give you a concrete example, if mobile crisis were to come out and respond to a new call, and that crisis exceeds the capacity of mobile crisis to address the needs of that situation, you might find that mobile crisis could make a direct referral to crisis stabilization as a step up from there. And then on the other side, young people who are being discharged from inpatient hospitalization, I know the community providers will often say discharges out of inpatient directly into like an OPCC level of care is frequently not an appropriate referral, but this would be and could be, I think, a good step down from inpatient level of care. So let me just pause for a moment and take Tammy's question.
Oh, thanks, Jeff. I had this kind of secret hope that the slide following the differentiation from inpatient slide would be followed by the differentiation from SFIT slide. And I wonder if you or Tim could speak a little bit to how the CSU is at this, kind of at this stage of the thinking being differentiated from SFIT.
Tim?
Sure. So recall that how we arrived. So in short, what Connecticut attempted to do with the SFIT model is to try to join what was our version of crisis stabilization and what would have been our version of the crisis respite. And so that was a challenge. And if you look at what crisis stabilization was supposed to have been, and I just recall that for those of you who have been around a long time, and I'm one of those, that during the kid care process, the 2002 to 2004 was when we were allocated $66 million to expand the service array that includes what eventually became a lot of what we have today. After the care coordination and mobile crisis, the crisis stabilization was rolled out, and crisis stabilization was in the midst of being procured in all in all 6 of the DCF regions, 2 regions at a time. And DCF, this is the second year of that 2-year allocation, got hit by that fiscal crisis, and the level of service that suffered was crisis stabilization. And so there were 2 or 3 components about that crisis stabilization system that never was fully built. One is it was supposed to be a full system. And again, it was supposed to be direct admission from mobile crisis. There was one procurement that occurred, and that was Region 2 and Region 4 at that time. So Children's Center of Hamden was funded and Wheeler was funded at the greenhouse. And then we hit the fiscal crisis. So the 4 other sites for crisis stabilization never occurred. So the challenge there was for those two providers to try to meet the model of practice without a full system of care in place to support all kids in the state. So that was a huge challenge. And the way the system was working, to some extent in the north with the greenhouse, there was a direct referral that tended to work. But down south in Children's Center, it didn't always work. So anyway, long story short, eventually those two programs got merged, if you will. And when we essentially developed SFIT, we were attempting to like hold on to some spots for a higher level of care for the community, if you will, and then some slots that were crisis respite for kind of the child welfare. And across the country, if you look at crisis respite beds, most commonly they are filled by kids who are from child welfare who just lost a foster placement and as they're awaiting another placement. So that's often the way that's used. So to speak more directly to the Connecticut model, SFIT was really this kind of attempt at a hybrid. And I'm not sure we ever were really, again, there's no criticism of the SFIT providers, more on can we really try to do two things under one roof? And I think that was one of the challenges. And then the other thing is, and I know that there's a lot of concern about SFITs, the repurposing of those, but the utilization rates for SFIT for the last 2 to 3 years have been very, very, very low. And people keep saying, well, they were always filled. Well, they weren't always filled. So there is an effort to kind of, again, develop some alternatives to that and to have something out in play. So I guess that would be my comment to that. Jeff, what I think might be maybe just, why don't we just finish up the slides and then we can break it up in for more conversation.
So I'll roll through. So hold on to your questions. There are not that many slides. I'll finish them up and then we can open it up for discussion. So secondly, de-escalating clinical acuity or distress. I think that you recognize that from the urgent care discussions, again, for youth that do not require inpatient psychiatric hospitalization, but need a longer period of time to achieve stabilization. And then following that de-escalation, the CSUs would be charged with ongoing evaluation and assessment of need, along with for youth all the way through emerging adults in collaboration with families and caregivers. A goal also would be to maintain youth in the least restrictive environment that's appropriate to their needs. And in many settings, you see that crisis stabilization units, or whatever they refer to them in that state, are very comfortable home-like environments. So they don't look and feel like a hospital ED, for example. They're much more kind of home-like, or I'm not sure how else to put it besides home-like, which is why it's on the slide. And then finally, increasing connected care rates. I think that's always an issue throughout our system, is how do we make sure that each level of care is charged with improving connected care rates for that next level of care when it's needed. And I think CSUs would be charged with making sure that connections are being made before discharge, that young people are walking out with an appointment for the next level of care. And finally, preventing or reducing admissions or readmissions to the EDs or inpatient psychiatric hospitalizations or PRTFs. Whoops. Last slide. And we are seeking, I think this is the slide where look at all these and decide where you want to provide us with input as a state, because I think we're going to need help fleshing out each of these categories. How are these going to be funded or financed? What does the physical space need to look like? What does the staffing and service delivery components need to look like? How do we want to train the staff to core competencies for delivering this level of care? What's the intended average length of stay, knowing that the maximum is likely to be around 14 days, but what's the ideal average length of stay? At the end of a crisis stabilization episode of care, how do we ensure appropriate discharge and connected care processes are in place? And then anything else that you want to add. So I will stop right there and open up the floor to any initial thoughts or questions or considerations that we need to look at.
Can you put that list in the chat? Staffing, length of stay, I already forgot half of them. Thank you.
Sure. Yeah. Sorry. And actually,
I can do
maybe Elise, if it'd be easier, we can probably just keep the that PowerPoint slide up. We could do it that way as well. Unless people really want to look at the grid of everyone's faces, some people do. I know that makes it easier to converse sometimes, but if we want to get started just with the list in front of us, and we'll see how far we get. So Christine, do you want to jump in first and comment on something?
Sure, of course, I can always comment on something. So I do think, so training and core competencies, again, if we're really thinking about mobile crisis as potentially as mobile crisis as a hub, we have a series of training that we're looking for all mobile crisis staff to participate in. So, I'm wondering if there's some way to kind of join those efforts in some ways. Just a thought on training in particular.
Yeah, I think it's a good point as we can contemplate this crisis continuum. If we envision that 988 and mobile crisis are going to play really key linkage and referral roles, I think cross training between 988 mobile and some of these levels of care does make a lot of sense. Jason, I see your hand up.
Morning. I had a thought, or more of a question, and it kind of goes between physical space. Well, it goes between a lot, but are there current spaces or places that could be converted to do this model? Because I think cost effectiveness, that's probably the best bet if there's something that can be converted. Otherwise, I think we all know, like, this is millions to be able to stand up new facilities, right?
Yeah. Tim?
And I guess, are there any thoughts on that?
Yeah, so my assumption would be that if the department was to move forward with this level of care, and potentially the alternative to the emergency department is one first step would be potentially two steps, request for qualifications and request for information. Usually those two steps prior to an RFP gives us a better idea about who out there is willing and able to provide the service. And then information often, and either one of those might suffice, but one or the other, or both of them might be needed. But that's really where we usually would hear about that. And then, so we would have a better way of knowing, okay, before you go to an RFP, how much money is going to take to really find out what the physical spaces are that are out and about.
So just to be clear, we're talking private, more or less privately run, non-state run. So not necessarily a state-run facility.
Correct.
So we'd have to get people to want to do this. Okay. Is there already a reimbursement model for this level of care?
There are not that I'm aware of in Connecticut. I do think that there could be some Medicaid codes. We're in discussions with DSS just in general about codes for the alternatives to the ED, and just need to get a sense about what things might be covered under Medicaid under that model. So we would likely do the same here for this model. Just to make a comment to finish that out, in Connecticut, those original kid care services that got halted in the crisis stabilization, the plan then in the blueprint that was the governor's Rowland's blueprint at that time was that the crisis stabilization units would eventually have some portion of their work covered by Medicaid and billable services. So it would be a combination of that. That plan was supposed to be a combination that never came to fruition. So it seems to me that we would likely put forth some idea that some of the services might be partially covered. But I don't think there's an intent that either the state dollars or either the Medicaid or the third-party dollars would fully cover the operational costs of this level of care.
I'm just seeing a comment from Rita in the chat. And it goes back to the discussion on SFIT just a moment ago, and maybe picks up on the physical space comment that Jason just made. Is there any discussion of using the current SFITs? I would imagine either whether you mean the physical space or the clinical capacity and staffing, or maybe all the above, to transition into this CSU model.
This is again a little bit area. This is we just need to acknowledge that in my head, when I think about all of the provider network that we have out there, the full continuum of community-based services, hospital-based services, I can imagine a number of places that may have some space, or entities that may be willing to consider space. Some of that might require new build, some of it might require renovational costs, et cetera, but that would be kind of the conversation around the request for qualifications and or for requests for information about who's out there, who would be actively interested in being able to do this, and how would they be able to accomplish it, and what would it cost. So again, I'd rather stay clear of saying, would SFIT be that? I don't know. Some sites maybe, some sites maybe not. I don't know all the SFIT's location and what kind of physical plants they have.
Carl, I don't know if you want to comment any further. I noted that I thought all the points that you made about just adding a level of detail to several of the bullets. I think we can certainly do that in our model document, more than we could fit onto a PowerPoint slide, but definitely will be part of the Word document. Anything else you want to add to that?
No, I appreciate that. Just recognizing that we're not working in a silo, and I've detected, interest, in these concepts in the outside world and expectations. So I think as we, engage in our next steps, we do make a concerted effort to start considering, the potential challenges and opportunities associated with implementation of this level of care. And these are just some thoughts that occurred to me as I looked at the list and thought, what else do I think needs to be on the list? So thank you, Jeff.
Yeah, appreciate that. Thank you.
I think that's one of the challenges of this kind of group is, and again, conceptually, the task is for us to kind of say what the level of care, this level of care would look like in Connecticut. And it's hard to do that in a vacuum and just say, let's pretend we're doing that without knowing what's out there and available. But really, as much as we can, that's our task. And then the secondary follow-up is then to start to think about that. I personally can imagine, and I think you all are also imagining, that depending on any particular site you think of, you would come up with, oh my gosh, that would need to be a complete rebuild, or that would need to be a brand new building, or that space might convert fairly easily and we'd be a low cost. So all those factors are what we can't really get into because there's a gazillion of those. And so the best thing we can do is to kind of put forth what we think would be the best practice model, and then again, see how these would evolve. I saw the comment about beds. My only comment about that is historically these levels of care and what DCF has done in the past, kind of 6 beds are on the smaller end and 10 or 12 beds would be on the higher end. Our experience with these kind would not be that there would be these huge buildings, if you will, of lots of beds. And I think 8 to 10 beds or 6 to 8 beds would probably be kind of the more, and again, that would very likely be different when you start getting into potential specific sites, if you will. But if money was no object and we wanted to build from the ground up, again, some of the characteristics being community-based, being as much home-based, being capable of dealing with a higher level of acuity, but it's a subacute rate, a subacute level of care, we wouldn't want to build a facility for 25 kids, for example. So that's just the main point there.
Okay, and Christine, to answer your question about timeframe, and then Carlos, I'm going to go back to your question. I think like we talked about with the urgent care, we're differentiating the urgent care model and the CSU model as being longer term solutions. You know, when we pivoted over to the short term solutions work group, you know, we talked about things that could be done much more rapidly than that, but I think this is something that we should be thinking about as a hopefully over the next 1 to 2 years, pending legislative authorization and a clear plan for how it's going to be financed and rolled out. I don't want to speak for, I'm just putting those out there as generals. I can't speak for the state agencies who would be responsible for procuring this, and I can't speak to the ultimate success of legislatively authorizing and kind of working through those challenges as well. So it would definitely take some, work to get this going.
I would just, sorry,
ahead.
just another comment. I just would add, I know Carl would be very familiar with this, but just to remind folks, the moment we're in now that changes all this is the pandemic. But to remind folks that this work group and the work that we have been doing has been in planning since 2014. And when we got kind of reinvigorated with my newer administration, which is not so new anymore, but after the previous administration, this work kicked into high gear, but that was also still before the pandemic. So these two levels of care, to develop them, were on the to-do list. And my administration said, hey, we got to dust that off and make sure we move forward with that. The pandemic then hit and has magnified the need and the problems that we have had, and why was an alternative to an emergency department on the plan in 2014 was because we had already known about the seasonal fluctuations and the seasonal challenges that emergency departments have had. And the pandemic has just, again, magnified that to a level that we've never seen. So those are all those. So we're now in this moment, still trying to move ahead in a thoughtful, planful way, but at the same time be accelerated by the pandemic. But these things are not, and were never intended to be, things that could be stood up in 3 or 6 months.
Okay. Sherry, to your question or comment about staffing concerns, I totally agree with you. If you remember a couple of months ago when we got to this point with urgent care as well and said, well, this is all well and good, but what if we can't find, we are already currently can't find staff. What makes us think that we're going to be able to find staff going forward? I think the only thing I could point to there is just, I think that many of you have been at the recent testimony that we've been giving to Children's Committee and some of these other meetings that have been taking place with legislators and others. And I do think that there's going to be a need to continue to advocate for some significant investments in workforce. At the end of, gosh, what was it? Tim, you were probably on it. Somebody mentioned yesterday, and I have not seen it yet, but there was a $10 million announcement of a new $10 million investment in healthcare workforce development. And I don't know if it's going through OPM or where it's going through. I think this came up on our child adolescent QAP committee meeting yesterday as part of the Behavioral Health Partnership. And I think there was a sense among that group, like, well, if there's going to be some money spent on workforce, we need to make sure that, or healthcare workforce, we need to make sure that a part of that is spent on the behavioral health workforce. So the things on the table that I've heard many of you who are on this call, providers talking about things like, of course, increase in rates and funding that create the base for being able to pay your staff, but also things like tuition reimbursement and loan forgiveness programs that can be targeted towards the behavioral health workforce, as well as other pipeline considerations like going in and having initiatives in high schools or colleges to get people interested in this field. And then the last thing I would mention is the potential role that Connecticut adding peer support specialists to the Medicaid reimbursed schedule could also increase the workforce in such a way that we'd be able to put licensed clinicians in other parts of the continuum if we were to add peer specialists to our workforce. So Sherry, it is a restrictive component, but I think we have to contemplate what this model would look like under the assumption that we could address the workforce issue by increasing rates and funding and creating these other financial incentives to bring people into the workforce.
Jeff, there was also a question from Christine prior to that around the time frame being considered.
No, I think I talked about that one. That was the discussion about really thinking 1 to 2 years on this and the need for legislative approval and distinguishing this level of care from some of the short-term solution work group conversations we were having. Anybody else want to, I'm getting a little bit behind on the chats. Does anybody want to come back off of mute and talk about something that they're either that they dropped into the chat or anything else that they want to raise?
Hey, Jeff, this is Ann Hogan. I had thrown in the chat, wondering if this model would be fully state supported so that any child could access versus Medicaid insured only. We see now commercially insured kids that can't access certain services. Just a question.
Again, I'm going to state my value on that without speaking for the state, but I think my personal view on that would be that we have to make things like this available to all children, regardless of insurance status. So if we need to blend Medicaid and commercial reimbursement together with grant funds to create capacity to be able to serve the needs of commercially insured, publicly insured kids, I think we need to blend and braid funding to be able to do that, and not just push this through the Medicaid system. But that's my personal opinion. Tim or anyone else want to comment on that?
Yeah, I just would remind folks that that was the driving force or one of the underlying values and principles that was driving the whole children's behavioral health implementation plan. And that one of the challenges that Newtown pointed out was that even if you have means, there were some people that really couldn't get access to treatment. So that we are considering all of our recommendations would be for all kids in the state of Connecticut. If there's a curveball that comes the way, that would, for one reason or another, we can't speak to that. But for us, putting this forward and promulgating it as for all kids in the state of Connecticut would be our value that we're promoting.
Okay, Tammy, I see your hand, but let me just, yeah, I'll go to you, Tammy. Let's go to you first, and then Carlos, I think you're raising an important point in the chat. So let's go to Tammy first, and then Carlos, if you want to come off of mute after that, that would be great.
Thanks, Jeff. I just really wanted to speak briefly to length of stay. I know that initially the talk, or initially kind of the concept that you were playing with, was around 14 days. I think probably that's right. I just wanted to remind people that we did have a CARES level of care, and that length of stay was 72 hours. And I think that length of stay was really insufficient to provide the adequate stabilization and connection to care, which often cannot be achieved within the 72 hours. So I just really wanted to say, I definitely want to, kind of speak for something longer, like the 2 weeks, like the 14 days, rather than something like 72 hours.
Right. Good. Very good point. Carlos?
Yeah, I was just, kind of struck by the seeming conflict between wanting a less intensive staffing and the fact that this will require some de-escalation, which, as we all know, comes in a variety of shapes and sizes depending on the kid, and will require a lot of input at first. I mean, later on, after de-escalation successfully takes place, you don't need that much, but in the moment, we're getting these kids right off of the street and they're being diverted from an emergency room trip. It may require, people who are really good at crisis intervention and, possibly the use of, urgent medications or medical assessment, that sort of stuff. So, I mean, I think you're going to need to temper your thoughts about less intensive staffing with the fact that, very acutely, you may really need a bigger intervention.
Yeah, I think it's a very good point. I went back and forth on the slides, to be perfectly frank with you, with Tim and with Elise and with others on that point, because I do think, and I think what we reached, where we landed on it was, we're at some point going to have to look at the full continuum of crisis-oriented services and start to make some determinations about how we're distinguishing between the target populations that are appropriate for each of these levels of care. So how are we going to be able to tell the difference between a child who needs inpatient level of care versus a child who needs crisis stabilization versus one who is going to be appropriate for behavioral health urgent care? And I think that is going to be, on one hand, it's good to have additional service elements in place as alternatives to the emergency department for kids who can be maintained in community locations. But we will have to be pretty sophisticated in how we're determining what those level of care needs are and ensuring that we're not cycling kids through multiple levels of care trying to find the right one, if that makes sense. And I'll invite people to comment further on that, but I do see Christine's hand up.
May I just jump in, Christine,
Sure.
first? I don't think it's an either or, Carlos. Yeah, and here's the thing, again, mobile crisis across the country is under tremendous pressure to actually have on their staff peers, particularly on the adult side. And peers as a group of advocacy individuals, again, particularly on the adult side, and on kids side, the peers being parents of children with mental health needs with kind of that lived experience, is that there's quite a number of stories that the peer community will tell where emergency departments, inpatient facilities, crisis stabilization units completely failed them, and it was some of the worst experiences they ever had. And that their whole advocacy stance on this whole crisis continuum is one other alternative needs to be support from a group of peers and who can safely monitor somebody who's in a acute crisis in a community setting. So my point is that the pressure on these crisis services is at the highest levels of saying, hey, you need the most qualified staff, you need kind of that, for lack of a better term, kind of in air quotes, a medical model. And then in the other extreme, you have, again, for lack of better words, kind of the quote unquote peer community-based model. And there is an intersection of those, and there is opportunity for both. Peers are in, particularly, I recall every year going to the AAS Suicide Prevention Conference. And at the last 2 days of that is all peers and survivors, both attempted survivors and lost survivors. And often one story after the next is how often they report how bad their experiences were in the higher levels of care, and that the higher levels of care have really failed the system. So I'm just recalling all that information. And if we were well stocked with peers on this call, I think we would hear that voice. So I'm understanding you that we need competencies, but I also think there's room for the peer support, particularly when, and I think you said this, at the stabilization end, and as you transition out of this crisis stabilization unit and into the next level care back home and back into the community. So I do think there's an opportunity. The question is funding, right? I guess that's always the big issue. Thank you, Christine.
Sure, no, just to kind of piggyback, I was absolutely thinking along the staffing. My comment is around staffing, and specifically, I mean, I think, looking at some of the model elements that were identified back in September, we talked about there must not be too acute exclusions for these beds. And again, I think that speaks to the possibility that there may need to be medication management readily available in these units. As well as the peer support and like everything in between. And I think that is definitely going to be a challenge here. How do we have the adequate level of medical support, medication support that may be needed, as well as a home-like setting. And so it's a really interesting balance. I was also just going to comment on in accessing SBIT beds. Often there was a challenge when kids were already on medication, and the unit that we would refer to, and maybe similar up at Wheeler, but meds needed to come in, new prescription from the doc, bubble wrapped, like there were all these parameters that then made it complicated if there was someone who was already on meds to go into one of these units. And so I'm just, again, commenting on that was our experience with SBIT, and how would this be different? or this should be different, I guess. And it was a long process sometimes to get kids in as a result of that.
Great. Mickey, I see your comment here about, again, I think very much like the urgent care discussion we had, recognizing ahead of time that we're going to see disproportionate utilization at this level of care among those with intellectual developmental disabilities, I think it continues to be a very important point in terms of staffing, service delivery, training, and core competencies, and probably other things as well. Doing a quick time check, Tim, we've got 8 minutes. We had set aside some time in the agenda just for kind of mapping out future directions, and we might want to pivot to that at this point.
Frank's got a question.
Apologies for raising my hand so late. I just want to echo what Christine just said, in thinking about availability for prescribing and getting folks on meds who are on these crisis stabilization units. My experience, what I've seen over the last 15 years is that we would admit a lot of kids who I think right now we would define as appropriate for a crisis stabilization unit, but we would admit them inpatient, and the benefit was just a rapid assessment with an experienced child and adolescent psychiatrist and getting them on meds and getting them out in 5 or 6 days and sort of setting the course of care. We are completely unable to do that now. I get calls every day from colleagues, friends, others, just reaching out about someone's 13-year-old, 14-year-old, who when I hear the history, I think that's the type of adolescent where we really could make a big difference, but we just don't have the room on any of our inpatient units now to do it because the acuity of all the other kids there is so much, it's so much higher, and so many kids are stuck. My fear of this is that if these crisis units really need to also be able to have very competent child and adolescent psychiatric support to get folks on medications. Otherwise, it'll be a revolving door. And one of the fears I have about separating it too much from inpatient is that then in inpatient, it's for those who truly meet inpatient level of care. They're going to be very acute places for any of our kids, and I'm speaking to the point that I think Timmy made the point of from peers or parents hearing where the state system has failed them. I think that's where it's failed them when there are kids that end up on this very acute unit and staff just don't have the time to really help.
Thanks for that, Frank. And Tim, if you want to, do you want to take the last 5 minutes here and just wrap us up?
Sure. So you can see by the conversation that we have a little bit more to do here. That said, we do think we have an outline and have been working on a draft of this and had placeholders for this conversation to occur. We'd like to get that out to you all electronically. Our hunch was that the group's choice was going to be to come back to meet one more time at least. We had a goal to get both of these levels of care and recommendations in originally by the end of November, the beginning of December. We have certainly realized that that may be a challenge, but our feeling is we still would like to try to meet by the latest mid-December date. So our suggestion would be either we try to finish this all electronically, or we get out the next iteration for everybody's feedback and then come back one more time on the first or second week of December. So our starting point was, the assumption was you would all want to come back. So let's do the opposite. How many people would like to just do it electronically? Raise your hand or give a thumbs up or wave at the camera. All right, seeing none, I'm going to assume that everybody would like at least one more meeting. So we would like to have that. We'll go ahead and get that out. I think, Elise, did we already potentially identify a date or two, or were we going to?
We have not yet. We just thought the first couple of weeks of December would be our target.
All right, so we will look to get an appointment out to you all for that. We are not likely to finish and have in hand a document even at the conclusion of the next meeting. However, we would still like to try to be done and say that next that meeting in December would be our last meeting of this group. So we would like to suggest that at the conclusion of that meeting, we get the final draft out to you, or as close to final, and then we finish that document electronically in order to meet kind of that mid-December timeline. So we'll ask you to kind of be responsive if you're able to following the next meeting. Tammy?
I'm kind of in the spirit of both and also in the spirit of our new hybrid environment. It would be great if there was a way actually to provide written comment on what would be the kind of, the meeting will provide opportunity for discussion and this kind of oral comment, but it would be great if there was an opportunity for kind of written comment that actually was accessible to the whole group. Like, so I could send you an email or Jeff an email, but then everyone doesn't see all the fabulous things I have to say. So it would be awesome if there was a way that people could see the feedback that you got. And I know like technology affords us that. I just know within what existing structures you have, how that might work. But that if I could have a wish, it would be mine.
Yeah, I think there is. I think part of the challenge is I know that the state system, that is not always easy to do when there's a public document under what is the program, Elise, that we could potentially use?
We could use Google Docs or
Yeah,
set up
something.
that's probably easiest. Yeah.
Yeah, something like that. I know that
Mhm.
I always have trouble getting in and out of the Google Docs, but I'm sure we could probably figure out a way to do that. So appreciate the comment. So that will be our goal. We'll try to do it, make sure everyone has access to it. We'd ask everybody to just, use the track changes process and put your comments in. And, if you have direct edit suggestions to do it all that way, but so that would give everybody an opportunity to weigh in on that. So thank you for that. 1 minute left. Anybody have questions
Yeah,
or
let
comments?
me just acknowledge a couple of things first. Yes, Christine, we will do our best to get that out at least a week ahead of time. I know that we have not always gotten things out with a whole lot of lead time. So we will do our very best to get that out about a week ahead of time before our next meeting in first, second week of December. And Carl, just noting your offer and appreciate that in case we do need a little additional time, we'll be in touch with you if we want to go in that direction. So thank you. And with that, folks, it's 10:59. I just want to wish everybody a happy Thanksgiving. I hope you get a chance to take a break from all this. People have been working really, really hard in our sector of the world. So get that relaxation time and have an extra glass of wine and a slice of turkey.
Thank you all.
Everybody.
Bye-bye.
Thank you.
Thanksgiving.